And we'll move on to the next talk, which is from Juan Bueren at CMAT in Madrid. And the title of his talk is Engraftment and Phenotypic Correction of Hematopoietic Stem Cells in Non-Conditioned Fanconi Anemia Patients Treated with Ex Vivo Gene Therapy.
Thank you very much, Helen, and thank you, the organizers, for giving me the opportunity of presenting the gene therapy trial we are performing in patients with Fanconi anemia Well, the disclosure is based on the collaboration that we have with Rocket Pharma. And to start with, as many of you already know, Fanconi anemia is a quite complex genetic disease that is associated with mutations in any of the 22 Fanconi genes that are already known. Nevertheless, mutations in FANK account for more than 60% of these patients, and this is the reason why we have focused our gene therapy trial in patients with Fanconi anemia A. Clinically, Fanconi anemia is also a complex disease that is mainly characterized by bone marrow failure. And as you can see in the slide, more than 60% of FA patients will develop the bone marrow failure during the first decade of life. In more advanced stages of the disease, these patients can also develop acute myeloid leukemia and solid tumors. Well, in contrast with many other diseases that have been treated so far by gene therapy, in the case of Fanconi anemia, the main phenotypic defects are observed not only in maturing and in mature cell compartments, but even in the most primitive hematopoietic stem cells. And this is the reason why the bone marrow of patients with Fanconi anemia contain significantly lower number of stem cells as compared to healthy donors. And indeed, this was considered one of the main limiting factors that prevented the success of gene therapy in previous gene therapy trials in Fanconi patients. Nevertheless, it is of significant importance the observation that the reversion of the pathogenic mutation, even in one single hematopoietic stem cell, was sufficient to revert the bone marrow failure of some patients known as patients with somatic mosaicism, which, as shown in the slide, progressively increased the number of peripheral blood cells, even for very long periods of time. So what we proposed to our regulatory agency was to mimic what was happening in mosaic patients, and therefore what we proposed was the collection of the stem cells from these patients in very early stages of the disease by means of the use of GCSF and plerixafor. These cells were purified and cryopreserved. So when signs of bone marrow failure were evident in the patients, these cells were thawed, transduced, and infused in the patients in the absence of any conditioning regimen. And this was done based on the evidence of ex vivo expansion of naturally reverted mosaic patients. In some patients that at the moment of the stem cell collection also met the criteria defined for the infusion of gene therapy, these cells were genetically corrected without any cryopreservation. Well, because of the fragility of Fanconi anemia stem cells, the transduction process was significantly reduced, and cells were transduced in the presence of lentiviral vectors where FANK were driven by the PGK promoter. As mentioned, some patients were treated with cells that were previously cryopreserved, in this case for up to 2 years after the collection, and other patients, the cells were transduced without any cryopreservation. Based on the number of vector copy numbers in colonies, the estimated transduction efficacy ranged from 17% to 53%, and the estimated number of corrected CD34 cells ranged from 1.7 to 4.1 times 10 to the fifth CD34 cells per kilo of weight, which is up to or even more than 10 times lower as compared to other gene therapy trials of diseases that do not affect the phenotype of the hematopoietic stem cells. Well, what this slide shows is the kinetics of gene-corrected cells in the peripheral blood of the 4 patients that were infused with corrected cells. Of course, in none of these patients, any conditioning regimen was used. So despite the absence of conditioning, after a latency period, we observed in all the 4 treated patients progressive increases in the proportion of corrected cells, which in patient 02, where the follow-up nowadays is 24 months, currently the proportion of corrected cells in peripheral blood is 45%. So we then asked whether this level of gene marking was specific for one specific hematopoietic lineage, and this is why we purified cells from different lineages, both in peripheral blood and in bone marrow from all the treated patients. And as shown in this patient, we observed gene marking in all peripheral blood cell lineages that were tested. This was not only in peripheral blood, but also in bone marrow, and it is of significance to see the expansion of corrected CD34 cells in the bone marrow of this patient, which at 24 months post-infusion, 50% of this CD34 population consisted on corrected cells. Well, in collaboration with Juan and Manfred Smith, we investigated the clonal repopulation of these patients, and as expected, based on the relatively low number of infused corrected cells, we observed an oligoclonal reconstitution pattern, and probably the most relevant observation that we noted in all treated patients was that increases in the proportion of corrected cells over the time were not due to any genotoxic event that may amplify a specific clone, but rather, as observed at the latest time point of analysis, the polyclonality that was observed at this time point increased in parallel to the proportion of corrected cells. And another important observation was to identify the presence of integrations that were common to all peripheral blood cell lineages, which indicates that we were transducing multipotent hematopoietic stem cells that were able to engraft and to expand in the bone marrow of these patients. Well, obviously, we were also interested in analyzing the phenotype of the hematopoiesis of treated patients, and because one of the hallmarks of FA cells is their hypersensitivity to DNA cross-linking drugs, and also the elevated number of chromosomal breaks that are generated by these agents, what we analyzed was the resistance of hematopoietic progenitor cells in the bone marrow prior to and after gene therapy. And as observed in the slide, progressive increases in the survival to mitomycin C were observed in all the 4 treated patients, and importantly, this was observed in good correlation with the proportion of corrected CD34 cells analyzed in the same biopsies where we did analysis of mitomycin C. And the same was observed when we analyzed the proportion of T cells that were free of aberrant chromosomes. As shown in the slide, progressive increases in the percentage of aberrant free cells were observed in the peripheral blood in these patients, and this was particularly evident in patients having higher levels of engraftment. So while at the very beginning the phenotype of these cells was the characteristic of Fanconi patients, this moved to phenotypic properties characteristic of mosaic patients, and in the case of patient 02, This phenotype is now getting closer to the one characteristic of a healthy donor. Well, in terms of the evolution of the bone marrow failure, as shown in the slide, it is evident based on the analysis of platelets and also of neutrophils, progressive declines in these two cell lineages, and how after gene therapy there was a stabilization, at least in those patients that were treated with higher numbers of corrected cells and which contained higher proportion of corrected cells in peripheral blood. And to understand more clearly what was happening in the hematopoiesis of these patients, what we analyzed in this final slide was the total number of corrected leukocytes after the infusion of these cells in this patient. And the slide what showed clearly is how the number of corrected leukocytes was increasing, while at the same time the evolution of the bone marrow failure was implying a progressive reduction of the number of uncorrected leukocytes in the peripheral blood of these patients. This observation, together with the significant reservoir of corrected stem cells that we have observed in the bone marrow of these patients, strongly suggests to us the high possibilities of rescuing the bone marrow failure of these patients in the long term. So taken together, we can conclude that so far no single severe adverse event associated with the gene therapy has been observed in any patient, that we are able to collect clinically relevant numbers of CD34 cells, at least in young patients when we're mobilized with G-CSF plus plerixafor, and we have observed that even patients were not conditioned prior to the infusion of the medicinal product. It was evident the engraftment and repopulation advantage of gene-corrected hematopoietic stem cells. We observed oligoclonal reconstitution and gene correction of multipotent stem cells. We demonstrated phenotypic correction of bone marrow progenitors and also in peripheral blood T cells, as well as stabilization of the bone marrow failure. So for the future, the idea would be to infuse higher numbers of corrected stem cells in these patients, and this will be performed both by collecting and infusing the stem cells prior to the development of the bone marrow failure, by means of the use of transduction enhancers, and also we have considered the possibility of conducting some mild conditioning to facilitate the homing of corrected stem cells in these patients, ideally with non-genotoxic conditioning. So talking about transduction enhancers, just to show you very preliminary results where we have observed that by the use of transduction enhancers we can increase up to 5-fold the transduction efficacy of the CD34 cells. And in the first patient that we have infused with cells that were transduced in the presence of the enhancers, we have observed, at least in the short term, that the presence of vector copy numbers in peripheral blood cells is significantly increased. So to conclude, I would like to acknowledge the people that is doing the work, very particularly Paula Rio and Susana Navarro, who are in the audience and who are instrumental people in this clinical trial. Also, I would like to thank Julián Sevilla and Cristina Díaz de Heredia, who are the PIs for the clinical trials corresponding to the gene therapy and to the collection of the CD34 cells. Many other people in the laboratory that is working in the GMP facility and also in the flow cytometry facility. Many colleagues from other institutions involved with the production of the vector, the genetic analysis of the patients, and so on, and very especially our colleagues from Rocket Pharma, with whom we aim the development of new therapies for the efficient and safe treatment of Fanconi patients. And of course, families, patients, and many colleagues that are part of the Fanconi Foundation in Spain. Thank you very much.
Thank you, Juan. Those are impressive results. Could you perhaps comment on what risk the patients are still going to be at from malignant events in the non-corrected cells?
Well, of course, We need to see what is the evolution of the corrected cells in the long term. What our hope is that if they have increased several logs during the first months after the infusion of the corrected cells, our hope is to have up to 100% of corrected cells. And therefore, what our hope is that risks of having leukemias as a consequence of the presence of the residual cells will be strongly minimized in these patients as compared to non-treated patients.
Okay. Maria Grazia.
Yeah, beautiful data, really compelling data. So if you say that with the enhancer you achieve a vector copy number around 2 and 3, do you, considering the massive selective advantage you have, do you still think we need conditioning?
Well, we think that the use of conditioning may be practical for several reasons. Maybe some patients will not be able with engraft, with a low number of stem cells we can be able to collect. And therefore conditioning in these patients could be useful. But conditioning will be certainly useful for 2 additional aspects. The first, to improve the polyclonality, which is something we always would like to see. We know that this is not necessary for the cure of FA patient because monoclonal reconstitution we know is sufficient in a mosaic, but polyclonality always makes us feel better. And the other thing is to reduce this latency period to facilitate the engraftment in a shorter period of time.
Thank you.
Okay. Thank you very much.